the Institute of Islamic Medicine, Art, and Culture. Discover the world of knowledge and exploration. At IIMAC, we believe in nurturing minds, fostering curiosity, and promoting multicultural learning experiences for all. We invite schools, libraries, and organizations for a unique opportunity to come visit us in Rolling Meadows, located in Chicago. Embark on an enlightening journey with our guided tours that inspire and educate. Our inclusive environment welcomes everyone, Muslims and non-Muslims alike. Together, we explore, learn, and grow. For more information, visit our website at iimac.org and experience the power of knowledge at UMAC, inspiring minds, igniting curiosity.
Hello, everyone. Welcome today. Assalamu alaikum. I am Mubin Syed. I'm Dr. Mubin Syed. I'm an interventional radiologist, and I'm going to be the moderator for today's session. I've been in practice for 25 years, and it's my major privilege and honor to have this talk today with Dr. Linda Bradley, who's going to be providing us with an excellent presentation on uterine fibroids. She's a professor of obstetrics, gynecology, and reproductive biology at the Cleveland Clinic, and she's also the director of the Center for Hysteroscopic Services and Menstrual Disorders. And her passion and interest has been minimally invasive treatments for the treatment of abnormal bleeding and particularly uterine fibroids. Before I start, I also want to mention real quick that there will be the book, The Contribution of Islamic Civilization to Medicine, the past and the present, inshallah, will be coming out in the next several months. And as you know, thanks to the work of so many people, and especially Dr. Mahmoud Hai, who's been the editor. So without further ado, I'm going to introduce Dr. Linda Bradley. And by the way, I've known her for over 22 years, and I look forward to her presentation. Linda, are you able to come in? Okay, great.
Yeah, hi. I'm here. Hi.
Welcome.
Thank you. What an opportunity and an honor. It is my distinct privilege to reach out and speak to this audience about my passion and what I really want women to know about uterine fibroids and getting the care that they need. So thank you for asking me. I think collaboration is important. I remember speaking before with a group, and I said interventional radiologists are our friends and not our foe. I think we work collaboratively. So it has been a long time since you and I have talked, but I'm glad that you reached out. We're both still vibrant and passionate about the work that we do. And I do hope that those that are listening can, find a clinical nugget, take something home with them, pass the word to others, pass this on to your archived video that we're doing today to friends that may benefit from this. So again, I'm honored, and thank you for the work that you and your entire team is doing. And I hope to get a copy of the book also. I think the more we know about each other, the better we do.
That would be exciting, yes. And of course, the context here is, we want to talk about some of the healthcare disparities that people of color often experience with regard to some of the treatments out there.
Absolutely. And I will touch on that with several of my slides. And then we have the question and answer session at the end where we can chat a little bit more.
Very good.
Excellent. So I guess I'll get started. And if I could have the first slide. So, it's great to be here this evening. And this is my life for the last few decades. I don't deliver babies any longer. And when I stopped delivering babies several decades ago, my friends, my husband, my family kind of said, what does a gynecologist do or OBGYN do if they're not delivering babies? And what we'll see today is that menstrual disorders, fibroids, in fact, there's a host of GYN problems that gynecologists need to take care of. For me, I entered gynecology with wanting to know more about fibroids, what options we can offer, because my patients wanted these options. For the last several decades, I've been involved with many teams with research, medication, surgery, collaboration with interventional radiology, and more. So I want to share with you what I call everything you want to know about the F word: fibroids, facts, fictions, and you need to know the fallacies. So my plan is to go through the slides, leave time for question. I'm not going to read through every slide, but give you sort of a flavor of what you need to know about different treatment options. So what are our options for this objectives for this evening? I want you to know about the most common and even uncommon presentations of uterine fibroids. What do you need to know about treatment options, from medical to surgical to minimally invasive techniques? And also it's important to review self-care. If you're suffering from fibroids, things that you can do to take care of yourself or those that you love. So I often use this phrase by Maya Angelou, who said, when you know better, you do better. As we'll see, so many women have uterine fibroids. It's important for whether it's fibroids, hypertension, diabetes, whatever our condition is, we need to educate ourselves. For many conditions, and I'm speaking tonight specifically about fibroids, seek multiple opinions. Build a strong support network with friends, with family. It's important to be curious about your symptoms, but also to document them. Keep a journal. Look at research or research treatment options. It's very important, as we'll see in a moment. I work at a tertiary care center, the Cleveland Clinic in Cleveland, Ohio, where we have minimally invasive GYN surgeons who have had extra 2 to 3 years of GYN surgical training in minimally invasive surgery. So sometimes a specialist may be needed for fibroid treatment. And not all doctors are the same. Not all gynecologists have the same skill set to offer some of the minimally invasive therapies. Communication is so important. Be open with your physician. Be honest. Let the physician know about your preferences, your concerns. Many patients, as we'll see, go 3, 5, 7 years with symptoms, and so they suffer needlessly. So advocate for an early diagnosis if you have some of the symptoms that we're going to talk about. Know your insurance. Know what it covers, what it doesn't cover. Again, advocating for yourself. Work with your healthcare team. We are not here to fight you. We are here to listen, to learn, to understand what you're passionate about for your body, what you would like to have done. And there should be an equal exchange and dialogue among doctor and physician. And it's important to have community engagement. You can join advocacy group. So I put here the White Dress Project, the Fibroid Foundation group, excellent for helping get other information for you. Now, what's the worst thing that you can do if you suspect that you have fibroids? And as a physician, just this week, it's amazing the number of women that I've seen that just ignored either symptoms, ignored what their physician or healthcare team wanted them to do. And so one of them is pain, pressure, increased abdominal discomfort, chalking it up that you ate too much, that you have lactose intolerance, that you're blaming symptoms on other things. So don't ignore your symptoms. Don't wish it away, but wish to find the answer that you're looking for. So many women minimize their heavy bleeding. Oh, Dr. Bradley, it's not that bad. Everybody in my family has heavy periods. But heavy periods should not lead to anemia, shortness of breath, fatigue, craving ice, losing hair, looking pale, not being able to do your exercise. So sometimes we've suffered for so long, we minimize it. Don't do that. Sometimes not being able to get pregnant or staying pregnant in terms of complications. Thinking that you're just gaining weight. I mean, who doesn't gain weight? But with fibroids, the size of the uterus can get larger. And so getting new dress sizes, pant sizes, people asking you if you're pregnant, that's not normal. And also it's important, doctors are looking at outcomes and we measure quality of life. How does all of this affect your physical well-being, your emotional well-being, your social well-being, your relationship, your hobbies, and sexuality? So we look at you as a whole person. Women are more than the sum of their body parts. And we must look at the whole woman with all of these quality issues to know what we can treat. So when we look at clinical impact of fibroids, it's very common. Lots of health risk. If you lived in a country where there's not a lot of food, there's not fortified food, anemia is a big issue. Fatigue is a big issue. And again, we find for quality of life, these other discomforts that we mentioned before, impact on work, your level of anxiety, depression, and things like that. It's something very real. This image just looks at the many faces of fibroids. And what we say is that while the majority of women, 80–85% of women may present with heavy bleeding, it may be multiple symptoms. You can have heavy bleeding. You can have pressure. You can have frequent urination. You can have cramping. There can be other problems, as we see here: bloating, protrusion of the abdomen, distension. So it doesn't mean just one thing. Some patients with fibroids only have one of these symptoms. So these I just want you to sort of be aware of. Also, we find obstetrical complications when women can't get pregnant, stay pregnant, have preterm delivery, have retained products of conception. The baby, instead of coming head first, it may present abnormally in the pelvis, leading to a higher risk of C-sections. Additionally, when the uterus is enlarged after the delivery, there could be postpartum hemorrhage. There could be potential with all the hormones of pregnancy that these fibroids grow and lead to a lot of pain and discomfort. So again, we can see problems outside of just GYN. Now, the important thing is to know when I see a patient with fibroids, the first thing on my mind is not cancer. It's about 1 out of 300 to 1 out of 500 patients who have fibroids will have a sarcoma. Who are those patients? Usually Black women in menopause, periods have stopped, and the fibroids grow, or rapidly enlarging fibroids in young women. We can do biopsies. We can do blood tests for LD isoenzyme. We can do MRIs looking for classic features of our sarcomas, but it's important that your doctor think about these things. There are other rare things that we see here, such as its association with renal cell kidney cancer, watery discharge, ascites, too much red blood cells. But again, we can see many different kinds of things. It's important when you go to your doctor and he or she tells you that you have fibroids, you need to ask the doctor what the size of the uterus is when they do your pelvic exam, ultrasound, or an MRI. A normal uterus is the size of a lemon. And the fibroids, as we'll see in a minute, can grow to be the size of an orange, a grapefruit, pineapple, watermelon. Some doctors will say it could be the size of a softball, football, basketball. And for fun, it was interesting that a study showed that if you go to a doctor and your doctor tells you your uterus is the size of a cantaloupe, and another doctor tells you it's the size of a football, usually the male physicians will use a sporting instrument or a sporting, not device, but, something, a ball or something. And female doctors are always talking about food. So know the size of your uterus, and you can follow that over time in addition to the measurements that we do. But I put pictures here, size, number, locations of fibroids really different. This lady down here, I hope you can see the arrow. She looks very pregnant. This is looking inside the uterus where a baby would be, and we see multiple fibroids in this space. We can see where the doctor is just taking out multiple fibroids. They're different sizes that we can see from myomectomies. Rarely, but once in a while, we will see, in fact, a case I did today is a patient with a prolapsing fibroid through the cervix. Lots of cramping, watery discharge, and this fibroid expels itself almost like a baby coming through. So it's important that when you see a physician that you get examined abdominally, that you get examined with the speculum exam to look to see. Sometimes these fibroids can be in different locations. So it's important. So how do we make the diagnosis? We ask questions. We do a clinical exam. We may use ultrasound, special types of ultrasound called saline infusion sonogram to look more closely inside the uterus where there may be fibroids there. Depending on the size, also the types of treatment, we may order an MRI. So it will vary based on your presentation and what the doctor feels on exam. Now, we speak often that fibroids affect women of the African diaspora, which it does, but fibroids are an equal opportunity problem. They are the most common benign growth. We talked about, $34 billion is spent every year. It's the most common cause of hysterectomies. By the age of 60 in this country, 1 out of 3 women has had a hysterectomy. Only 10% of hysterectomies in the US are for cancer. The others are for adenomyosis, fibroids, bleeding problems, endometriosis. So again, lots of women will have fibroids, up to 70% of white women, 80% of Black women. But in Black women, they occur earlier, they're more numerous, they get larger and create more symptoms. So again, lots of hysterectomies, over 600,000, about 125,000 myomectomies. Deaths related to hysterectomy can be from infection, bleeding, blood clots, but it's not something that we think of that often, but just be aware of that. So again, we just talked about the epidemiology, race matters, women who are over their ideal body weight, hypertension. Drinking 7 beers, alcohol per week is probably not good for anybody, but we find that increases a risk for fibroids. And women who have more children will less likely have fibroids, and women who smoke may have decreased. I think that's what I said, decrease fibroid risk, but we don't want you to smoke to decrease your risk of fibroids. And so why are there differences in care for women of color? Well, there are many different things. Race and racism may be an important role in this. Delayed diagnosis. There are many doctors and teams who do not have culturally competent care and bedside manner. There may be biases. Socioeconomic, where you live, work, play, and have your hobbies may affect the kinds of quality of care, access to top-notch hospitals, access to minimally invasive surgeons, awareness of a problem, and sometimes culturally. Fibroids sometimes run in families, and many women may say, everybody in their family, oh, my grandmother, my auntie, my sister had this problem, and they just assume that it's okay. So this may be a stigma getting healthcare, and therefore it leads to a later stage of diagnosis. Now, I was involved with several studies back in the day, many years ago, just looking at asking close to 900 women, close to 1,000 women, about the impact of fibroids. And this is amazing. We surveyed 968 women. The average, some women waited 3.6 years before getting treatment. 41% of patients saw 2 or more healthcare providers before their diagnosis. 28% of them missed work activities. I've had patients say that they're fired from their job because they can't get a break to change their pads every 30 minutes from heavy bleeding. There are patients who say that they believe that their symptoms prevented career potential. Had women who were offered opportunities to travel, to sit in business meetings, to work at different places, but their periods would just limit them. In fact, so many people during COVID have said, COVID was a blessing. And I'll say, well, Mrs. Jones, why do you say that? They said, because I can work from home and I can get up and change my pad as frequently as I need to by putting myself, on mute or hiding my face. So again, that can be an issue. And 77% of patients desired treatment that did not involve invasive surgery. Half the women wanted to keep their uterus, and 43% of women wanted fertility preservation. So we find that this is a big request for patients. Again, these other healthcare disparities, we can see the burden of disease for Black women. And again, there are many, many sobering statistics. High rates of hospitalizations for pain, 3 times the rate for Black women. Myomectomies are also high among Black women. more symptoms, more severe disease, impact on outcomes of obstetrics, earlier disease, and they sometimes grow more rapidly in the perimenopausal years. It's been thought that as women get into their mid-40s to 50s, that the hormone levels are dropping. Among white women, the fibroids kind of tend to stabilize, but in Black women, they can continue to grow until menopause, where the ovaries go to sleep and estrogen levels are low. So I just want you to be aware of that. These are some other racial disparities that we see in terms of complications from surgery, hysterectomy, and things like that. So this is all well known. One thing I really want to speak about is that almost everybody has fibroids. And one of the things that we're seeing for disparities in healthcare is that Black women have 60% higher rate of death from endometrial cancer. Endometrial cancer is not fibroid cancer. Endometrial cancer is cancer of the womb, the lining of the uterus, the endometrium. And many Black women, I've seen so many in my career, will start having bleeding when they're 60 or 70 or 80, and they hide it or they minimize it or they deny it. Because what they'll come in finally and say, Dr. Bradley, I've been bleeding for a year or two. I had these fibroids when I was younger. They were so heavy. I got blood transfusions. I missed work. So those fibroids don't go away. They go to sleep. But this bleeding, so if you do imaging, you will see the fibroids, but they're there. They're present and a passenger, but they're not a problem. So when a menopausal woman, which means you get to about 51 to 58 and your period stopped for a year, you should never, ever, ever see blood again. It should not be a first thought of cancer, but your doctor needs to know about it. And fibroids in menopause should be pretty dormant. So when a woman, if you present, or your grandmother, mother, or yourself in menopause with bleeding, we have to think about the endometrium. Do you have precancer, polyps, fibroid inside the lining of the uterus, endometrial hyperplasia? And we do think about cancer of the fibroid if the uterus all of a sudden is starting to grow. So don't deny those symptoms, even though the bleeding is often less heavy if it's due to endometrial disease. Again, we talked about the average age of hysterectomy is 42. Most hysterectomies occur 75% between the ages of 20 and 49. And we now have many more new ways to treat these conditions. So the question is, does every woman need a hysterectomy? What are the new options? And I'd like to bridge to sort of look at that when women are having symptoms. And what's happened to my career and why I became passionate about this, because so many women of both races are having children later, and they want to keep their uterus. So they're concerned about impacts on sexuality, femininity, fertility preservation. People want to remain intact. They want to know options. If we take out the uterus early, before menopause, even saving the ovaries, 20 to 30% of women can go into premature menopause. So earlier morbidity from hysterectomy, 7 things: weight gain, potential decreased libido, premature menopause, diabetes risk, cardiovascular risk, cardiac arrhythmias. So again, we're finding that early hysterectomies we want to avoid when there are other options for patients. And it may also be cultural. So these are the things I just mentioned about the long-term risk, and we really do not want to do early hysterectomies in women. So why do I embrace options? I've done this for us. I think it differentiates our practice. We are well skilled at the Cleveland Clinic and with well-trained physicians, and we offer medical, surgical, collaboration with our interventional radiologists. So it allows patients to have multiple opportunities for therapeutic treatments. Every fibroid cannot be treated the same. And so I look at our institution that we have the ability to offer not every single one of the technologies we're going to move into, but many of them. And so it teaches our residents, our fellows, and we have increasing volumes of seeing patients to offer these excellent options. So certainly there are patients who come in and it is your choice. We have to be patient-centered. What does the patient want? Some women want definitive treatment. They don't want to hear about medical therapy, uterine artery embolization, or anything like that. So we work with the patient, but when possible, to let them know when minimally invasive techniques or medication may be advantageous. So how do we divide everything up? Sure, hysterectomy treats everything, but what's your goal as a patient? Are you looking to preserve fertility? That is important. Even when you see your doctor and they say to you, you could be 25, do you want kids? Maybe you don't know, but make sure you say that. Some women are certain they don't want children, and it's important to have this fruitful conversation because preservation of fertility will limit certain treatment options. Doesn't mean that there aren't treatments, but there are certain procedures we will not offer if you want kids, or you're equivocal, or you're uncertain. And so there are also patients who want to preserve their uterus. And so we look at medical treatments, interventional treatments, and surgery. So I'm just going to briefly go through some of this. And it is important as we talk is to know your size, your number, and your location. Because every fibroid, as we saw earlier with pictures, they come in different shapes, sizes, and location. So we look at, and this, I don't know if this is showing, this is inside where a baby would be. This is in the myometrium or muscle. This is a fibroid on the outer wall. I've seen a fibroid like this, the size, the rest of the uterus is totally normal, but it's something that's the size of a basketball that's attached by a thin stalk. That's a myomectomy that's so simple for a physician to do, to treat. But all of these kinds of things must be individualized. And we've talked about the importance of thinking critically about what you want. Size, number, the severity, the location. So again, I put that in there again. And then we have to figure out what are your symptoms and what will this treatment offer you. So for instance, we're going to talk about some medications. Lystatin, tranexamic acid, very good for helping with heavy periods. But if your fibroids are so big and it's making you urinate all the time, urinary frequency, or you can't urinate, or you have such constipation and you have heavy bleeding, if your main symptom is bulk, B-U-L-K, which means heaviness, pressure, bloating, and you may have heavy periods, but that doesn't bother you much. The doctor just gives you medicine for heavy periods. You're not going to be satisfied. So we have to look at all these symptoms. Miscarriages. Do you want kids? Have you had pregnancy complications? Sometimes surgery, but uterine preserving surgery like myomectomy is important. We do a lot of imaging. If you have heavy menstrual cycles with a normal uterus, we really like to do saline infusion sonogram, which allows us to look really closely. This is just an image of a fibroid in the space where a baby would be. This is a surgery. I did 4 of them today, just taking out these fibroids hysteroscopically. The patients go home, hour or 2 after surgery, go back to work in 48 to 72 hours and resume activities very quickly. But this is a unique location. We call this an intracavitary fibroid. These are MRIs. I don't know how well this shows up, but a huge fibroid. This is the belly button. This is almost going up to the xiphoid. This is a smaller fibroid just within the muscle of the uterus. And so we can see well with MRI imaging for that. This is, again, a fibroid inside, like today, inside where a baby would be. So we can treat that with a hysteroscope. So these managements we'll speak about. There was been some medical therapies that I'd like you to know about, IUDs that we're using, types of myomectomies from hysteroscopic to laparoscopic to robotic to vaginal myomectomies, other kinds of procedures called radiofrequency ablations. And again, we're speaking about different ways to do hysterectomies if that's an ultimate desire. So most often, 85% of patients with fibroids will often have some type of menstrual problems. And I love this picture. I took it years ago. If your periods are so bad that you are wearing a diaper, you need to see a gynecologist. This is not normal, okay? Women should not miss work, leave work, take extra clothes to work, bleed through mattresses, bleed through soil through your chairs, being socially embarrassed. that is not a normal menstrual cycle, and you should see your physician for a workup. HMB, which is heavy menstrual bleeding, is often the driver for patients to seek treatment for concerns that we just talked about, the social embarrassment and things. So we offer medical therapy most often if that is just heavy, regular, predictable periods, nothing else bothers you. We might offer some of the therapies that we're going to talk about. Sometimes we offer medical therapy to stop periods to get you ready for surgery so you're not anemic. Patient I had, normal hemoglobin is 12 to 14. I met her a couple of months ago. Her hemoglobin was 5. I told her she's walking around with a half a tank of blood in her body, tired, fatigue, hair loss. African-American woman, looked pale. Her hands were pale. Sclera of her eye, just everything was just very different. So again, medical therapy is offered for many, many patients. And we'll talk about these therapies from IUDs to birth control pills to some other things. So I'll just move through. Now, depending on the size, number, and location, the Mirena or levonorgestrel IUD for a woman that has fibroids that are not like this one. This is inside the uterine cavity, but we can put a little device in that for 8 years now it can stay if someone doesn't want children. It's a method of contraception, liberates a small amount of progestin hormone so that there's minimal bleeding. Half the women within 6 months don't have a period. There's a drug that's been around in other countries for 30 or 40 years, over the counter in India, Canada, Sweden, most of Europe. We call it tranexamic acid. Here in the US, it's a prescription, safe to use for heavy, regular, predictable periods. 2 pills every 8 hours for 5 days may decrease bleeding significantly. So again, your doctor I just want you to be aware of some of these things. Even meds called NSAIDs, Motrin, Meclamin, Anaprox, ibuprofen. We think of it for menstrual cramping, but the biochemistry behind what we call prostaglandin levels can decline, and you can combine an NSAID with other therapies like the Lysteta to decrease menstrual bleeding and cramping. This is Lupron, has been around. It's an injection that's given every month for up to 6 months to stop the menstrual cycles. That's an older treatment, causes some hot flashes and night sweats. What's new since 2020 and 2021 are what is called GnRH antagonists. It's oral, it's a pill. One pill is twice a day, the other is once a day. We can use it for up to 2 years, best for heavy menstrual cycles. And we're doing studies now to see if the size of the fibroids, the bulk symptoms may improve. This is excellent for women who have heavy bleeding. This is not a method of birth control, but it can help to stop periods or make them very, very light. And this is, again, this new GnRH antagonist. So we can talk more in the question and answer session. So we can even see this is one of the GnRH antagonists that was studied. These are women measured, we call it the alkaline hematine assay. And thank you, women, for sending in the pads and tampons where with this one test, we can extract the blood. And look how much blood women were losing during a menstrual cycle. And it can go down to much less with this therapy. So again, very, very helpful. Uterine artery embolization has been around for a while. It's for the treatment of uterine fibroids. Contraindications, we usually do not offer it if women want children, if there's concern about cancer, an infection, some other things that are on here. But it really, really is well utilized at our institution. Traditionally, it's been done through a femoral approach. We now have many of our doctors going actually through the radial artery to feed this microcatheter all the way to the uterine arteries. Let me see. I think I have a picture of this. So we can see all this is a fibroid with all of this blood flow. What embolization does that the radiologists do is to basically block the flow of blood to the fibroids. So it's kind of makes the fibroid, starves them. So when they're not getting fed all this blood supply, you can see all those little micro vessels went away. Then the fibroids will shrink, decrease in size, heavy bleeding, bulk symptoms, and size of the uterus gets smaller. And it's now an outpatient procedure for most, or a 23-hour stay. Classic picture that was taken from an article, patient with a large fibroid. And then you can see had very heavy menstrual cycles, and over time, the size of the fibroid has gotten smaller. So again, the pressure effects, this is the bladder. So when you have something that's very big, it's sitting on the bladder, women either go to the bathroom to urinate frequently, urgently, or can't urinate at all with urinary retention. This is a bar graph just showing that your amount of your bleeding can decrease by up to 60 to 80%. So the flow dramatically drops within months afterwards. Now, we are still very conservative at the Cleveland Clinic. If you want a baby and have fibroids, you're more likely to have what we call a take-home baby and good outcome with having to find a great surgeon for a myomectomy. Greater risk if you have an embolization for hemorrhage, miscarriage, potential for endometrial scar tissue developing. So we don't recommend embolization at our institution at this time. Rather, we would prefer the patients who want babies have surgery. So we can see for uterine fibroid embolization over the last several decades, very high success rate for heavy bleeding, pelvic pain. So if you present with heavy periods, you tell your doctor you have pain, you're going to the bathroom frequently, or constipation, and the size of the uterus may decrease about 40 to 50%, and you don't want kids, this is another great option for you. But there are some nuances about who gets it and who doesn't. But this is why we're teaching you this, so you'll have the language to ask your doctor why or why not. There's something called MRI focused ultrasound, where basically the patient lies on this bed and there is an ability for the MRI to focus a beam into fibroids. You can see the fibroids and basically desiccate these fibroids and decrease the size of this through heat. And so I won't go through all the details, but again, I just want you to be aware of this. There's less patients candidates for this because sometimes scar tissue where the bowel is, different kinds of things. Our hospital at the Cleveland Clinic right now does not offer this, but I do want to mention this because it is offered in different places around the country. Another technology that's being offered is a surgical procedure. Again, it's just called radiofrequency ablation, where through the laparoscope, the physician can basically put these probes into the fibroid, step on a button for lack of a better word, desiccate, heat the fibroids, and they can also decrease in size, leading to outpatient procedures, less blood loss and traditional surgery. And I think we have in here decrease in size, improvement in bleeding, and short and long-term satisfaction. Short-term satisfaction, we know more studies are being done for the long term. So again, this is just things that we are seeing. Patients are pretty happy with it. When we look at minimally invasive surgery, if you have to have surgery, we try not to do these large vertical incision, up and down incision, or big bikini incisions. We have the laparoscope, which lets us use small incisions. Our patients often go home within 4 to 6 hours after surgery. They can get back to activity sooner. They don't take as much pain medicine. Less risk for complications, less risk for infection. But you often, for minimally invasive surgery, need to have a well-trained, qualified physician who has had extra training for this kind of procedure. This is the hysteroscopic myomectomy. Again, just go through the old word was DNC. If someone offers you a DNC, that is not the right surgery. You want to know that someone is using a tool, a hysteroscope, to look in the uterus and actually see what's there and then cut that away. Not just scrape blindly and not take out the fibroid or leave parts of it. It has to be hysteroscopically guided treatment. Again, just this is what I do a lot of. We can get huge amounts of fibroids. So this is a before picture and an after picture. This patient could have no baby's going to fit in here for pregnancy. Now the uterus heals and looks normal. But this is a fibroid that's intracavitary. And again, we can see if fibroids are in this location over time, a low rate of recurrence and need for hysterectomy. There's a lot of myths in medicine, that keep doctors from offering it. We say myomectomies, whether it's laparoscopic or open or robotic, it's too hard to do. It's too bloody. Patients can't get pregnant. That is not correct. Okay, we find that patients do well with this procedure. And there are many different ways. Again, I'm not going through this, but doctors offer laparoscopic and robotic approaches where they can go through tiny incisions in order to remove the fibroid, send it to pathology, close the uterus back, and leave the uterus normal. Sometimes fibroids, this is a vaginal picture. This is the cervix. This is not a baby coming through. Sometimes the fibroid actually prolapses through the cervix. So it's important that a doctor examine you, because sometimes ultrasound doesn't pick this up. So it's very important. These patients, if you ever have just profuse discharge, bad cramping, bad odor, make sure your doctor's doing a pelvic exam with a speculum to look inside, because this fibroid is different in terms of where it's located. Abdominal myomectomies are sometimes needed because some fibroids are, quote, too big to be treated laparoscopically or robotic, but there are minimally invasive techniques that we can do during surgery to decrease blood loss, decrease pain, get early ambulation. We call these early recovery methods, getting people up, walking, eating sooner. But this is not a dead procedure. There are certain patients who still do need, like the bikini incision, but you would talk with your doctor about this, or this is offered if you do not want a hysterectomy or are looking for children and your uterus is too large with the number of fibroids to undergo laparoscopic procedures. Hysterectomy should be your last choice. If your only choice that your doctor offers you and you want a baby or you want to keep your uterus, depending on your symptoms and everything, make this your last choice, okay? And if it has to be done, it should be done minimally invasively. Again, we talked about the benefits of smaller incisions. We used to call it keyhole surgery, but again, patients sometimes just go home with Tylenol, small amounts of Motrin, very little need for Percocet, Demerol, high-dose narcotics. We're always concerned about folks getting addicted to medicines with surgeries that take 6, 8, 10 weeks to recovery. So patients do better with the smaller incisions. Sometimes if a hysterectomy has to be done and the uterus is of a certain size, the physician can actually do it vaginally so that there are no scars. Quicker recovery, these patients go home the same day and can do well. But again, the size, the number, location, and the expertise of the surgeon will determine if this is an approach for you. Now, some things that you should ask your doctor about if you're confronting with this, not so much asking, but taking care of yourself. I mentioned some of the questions that you should ask if we've gone through this. I now want to just move into things for self-care because especially for bleeding, think about eating well. We are what we eat. So depending, some people I'll mention here are vegetarian. We'll see beans, green leafy vegetables, fruits, raisin, apricots, some other kinds of things that are fortified can help you improve your blood count as you get therapy. These are some iron-rich foods. And I tell my patients, just Google things. Pine nuts are very expensive, or you could have allergies. You may find things that you like on here, but I always say, go to Google, put in what are the most, iron-rich foods. And when you copy the list or look at it on your phone, you go to the store, buy those and eat those in plenty of quantity and add vitamin C to your regimen to help it absorb iron from your foods and from any oral iron that you're taking. This is self-explanatory about, mixing and matching foods and things like that, having a variety of foods. It's very important to try that. I'll just kind of get through this. If you don't like meat, we can see there's other sources, fish with the highest sources of iron, from fresh or canned tuna to purge to salmon, all these kinds of things. So at the end, I would say it's important for you to learn as much, and hopefully this session has helped you. Journey your symptoms, keep a menstrual diary with the length, the duration. Look at the quality of your life. How many days of work are you missing? Are you having pain? Have you given up kinds of things? How do your symptoms really affect you, and don't minimize them? Write down your questions before you go and see your physician. If the doctor explains something to you, repeat back what you can say, doctor, is this what I heard you say? Because sometimes we may interpret what we say incorrectly. And then again, sometimes getting a second or third opinion is so important. So there's lots more that I can say. I know this is a lot of material. I wanted to leave time, which we do have, and they asked me for 15 or 20 minutes. So I think if there are questions on the chat or however I need to speak at this time, I'll turn it back to you guys for next part of this. And I just want to thank you for your attentiveness. Hopefully you found a clinical nugget that will help you. And I'd love to answer any questions that you might have. Thank you.
Thank you, Linda, for this excellent, really comprehensive presentation. It was very eye-opening about so many interesting things. I actually didn't realize the risks for early hysterectomy,
Right.
that people experience. And this is overall, this is just, fibroids in general is such a major public health issue for women and particularly people of color. You talked about so many different aspects that were really interesting of how when to see a gynecologist, and particularly when people do need treatment, the revolutionary, it seemed to me pretty revolutionary, less invasive treatments for fibroids, including even the less invasive treatments for hysterectomy.
Correct.
And I thought it was very interesting what you mentioned about, postmenopausal bleeding. It has often not anything to do directly with the fibroid. It's due to
Correct.
endometrial cancer. And
Correct.
people,
Mhm.
you have to be very suspicious of that. And then, of course, sometimes it can be due to leiomyosarcoma, where the fibroid does turn into a cancer.
Mhm.
And particularly the prevalence in the African-American community, and how particularly, the rate of hysterectomies in African Americans is like 7 times worse, higher actually than for white women. That was very, eye-opening there. And, by the way, I did a little bit of research on South Asian women because there was a study on, some different ethnicities that are affected. And I was interested to find out that perhaps not as much as for African-American women, but they do have increased risk for fibroids.
Mhm.
And also but their increased risk is also for solitary fibroids.
Yeah.
Which was sort of something you may not necessarily expect to see as a presentation.
Mhm.
And then in the end, you're mentioning some really interesting things about managing fibroids. I thought, less through medical treatment, including diet, which I was very impressed about, how that certain foods, when taken together, can actually increase your iron absorption.
Mhm.
And then, of course, there are certain foods that decrease your iron absorption.
Correct.
So this is all really fascinating. I was just thought it was very, very comprehensive.
Thank you.
I don't know if there's any questions from the audience. I was, just for everyone to keep this in context of fibroids is again such a major public health issue. 80% of African American women and 70% of white women are affected, and I think a lot of other people, in particularly, are affected by this, of different ethnicities, particularly South Asians. And I guess if there's any other questions.
Are there any? I can't see if there's anything in the
Yeah,
chat.
I'm not seeing any actually.
Okay. Well, I think, like I said, I think I won't hold this on. We'll always say give people back their time, but
Yeah.
it is just important to not ignore symptoms, to be persistent, to have a conversation with your physician. And I think unlike 30, 40, 50 years ago, we did not seek out second opinions. And I think it's important to use, to use second opinions. It would be a rare reason that someone needs an emergency surgery where you would not have the time. And I think if you don't, intuitively, you don't feel good about the relationship with your team and your surgeon or your hospital, it's important to find the care that fits you. And it's important.
And that's crucial to know that there are alternatives to, the hysterectomy that you
Correct.
described.
Correct.
All of the major advancements in technology, that I think it's really revolutionized the care of fibroids.
Yes, I totally agree.
Yep. Well, thank you so much, Linda. It's really a pleasure and an honor and blessing to have you here and to give this fine talk. And thank you so much.
Thank you. And thank you. And I hope everybody has a good evening. Take care. Okay.
All right. Take care.
Thanks.
Thank you.
Okay.
Bye-bye.
Bye-bye.